We're now moving into session 3, where we will be looking with the witnesses at the community issues and the work of GPs and the effects on the community of the proposals and broader NHS issues. But first of all, we have some videos of witnesses to the Commission.
How did your job come into existence? Whose initiative was that?
It was brought to, it's an American evidence-based programme of 30 years standing, and it was brought to the UK by the Labour government in 2006 by a social inclusion unit, as it was seen to have proven outcomes to increase social inclusion and reduce things like conduct disorder. So it was brought to the UK by the Department of Health in 2006 and first started in 2007, and in Lewisham the programme came to Lewisham in 2010, January 2010. We've been given funding to expand the programme in Lewisham, so our team will increase by a further 2 nurses this year to reach a wider population.
How will the proposed changes affect you, your work?
They'll have a huge effect on the lives of the young women and young men and women that we visit in the home. Their majority are economically and socially disadvantaged, and they do rely on Lewisham Hospital for antenatal care, for the birth of their children, and to use accident and emergency when necessary. So relocating to a hospital, for them having to go to a hospital that's 5 miles away and more than an hour on public transport will have a massive impact on their health. Younger parents can book later than older parents. They have a 25% higher chance of having a low birth weight baby. Lewisham has worked very hard in the last 5 years to reduce low birth weight in babies. Low birth weight babies, the effect of low birth weight on babies has a very profound impact, not just in the immediate time after birth, but also throughout life. And Lewisham had a very high low birth rate compared to the rest of the country. But after 5 years of hard work, and most of that attributed to booking early and having direct access to midwifery care so that young women don't need referrals, the birth rate, the low birth weight has greatly reduced and is now on a par with the rest of England. Finding the money to use public transport when you're on a very low income is very, very difficult, and we're very mindful when we run groups for our young parents that it's very hard for them to actually access groups because they can't afford to travel. And it does worry me greatly that young parents having to access care in Woolwich, it will be too far and too costly and may lead to them not accessing those services.
Also, there are going to be lots of difficulties for people who are unemployed, paying for taxis, for travelling a long distance. Disabled people, they'll need lots of car parking, disabled parkings. Nowadays, I find that a lot of disabled people haven't been allowed disabled badges, which the government is just using the test system to take away the badges from them. There are people who have long medical conditions, they can't stay and travel for a long time, and if they have to wait there, I think it's going to be very, very difficult, because they have some people have to take their medicines in between every day after 3 hours or 4 hours. So it's going to be very, very difficult for people. Also, there are going to be seating arrangements in the hospitals where there are long queues, people don't get space to sit down, chairs are all full, people can't sit down. People are going to be really, really unhappy about that. There are going to be a lot of complaints, so there will be a lot of paperwork being generated. I would say that these things have to be considered when they think of closing the services in the Lewisham Hospital.
Hospital, Brook Hospital, Seaman Hospital, Sidcup Hospital, the all hospital closed now.
If I tell you a bit about how I managed things with Ray, he had his first treatment at Lewisham Hospital. Lewisham Hospital identified that he was beginning to develop leukemia, and he had chemotherapy here. There was a 50-50 chance that it would be successful. Unfortunately, it wasn't. And then they proposed that he should be treated by guys to see if he would be suitable for blood stem cell transplant. All of that worked out that it was feasible. So he went to Guy's and was looked after there. But part of it was that his immune system was compromised. So that meant he was vulnerable to infections. And unfortunately, a lot of the infections happened late at night. Now, when his temperature got up to a certain level, I'd have to ring the on-call haematologist at Guy's to be able to find out what to do. Guy's is not an admitting hospital, so we would have to come to A&E at Lewisham, and Guy's would ring Lewisham and all the arrangements would be made. He'd have to come in through A&E, they had to identify what the infection was and then work out what the treatment should be. On those occasions, it was late at night and I brought him in by car. I didn't call an ambulance. If this goes ahead, were I to be in the same situation again, I'd find myself calling an ambulance. I couldn't trust myself to drive late at night when I'd been looking after him all day. So that means we have to call an ambulance. Now, the ambulance service is under pressure. The administrator has not looked at what's called the unintended consequences, what it means for the other services.
I'm a GP. I've been working in Bexley for the last 10 years. I'm one GP in a two-partner practice. We run a personalised list, and I feel a very close connection to my patients because of that. My feeling about the proposed changes are that overall they present a significant risk to patient safety, and this is why I've become involved. We've already witnessed one A&E closure in South East London, Queen Mary's Hospital, Sidcup. And I've noticed since the reduction in capacity that followed on from A&E closure, my patients are being prematurely discharged, aren't really getting assessed because they're presenting to overstretched A&E departments, either at Queen Elizabeth's or Darrant Valley or the Prue in Bromley. And I fear with another A&E closure, this will just put on more pressure on existing services, which are finding it difficult to cope. On many occasions, I've been reassured that, in fact, further closures might improve patient care. But this is beyond belief. The people in responsible positions are misleading and lying to us about what is obvious to everybody.
Spending on mental health has increased hugely in the country over the last 5 years, from I think approximately 77 billion in 2006 to 105 billion in 2009-10, and that reflects increasing mental health needs. In a young, relatively deprived borough like Lewisham, where the average age is between 30 and 40, there are very large numbers of people suffering from mental health problems. Both the common mental illnesses like depression and anxiety, panic attacks, phobias, but also there'll be nearly 3,000 people suffering from a very serious form of mental illness like schizophrenia or bipolar affective disorder. And in any planning for the health of the local population, we need to make sure that services are coordinated, because fragmentation of care, and particularly the old dualism between physical health and mental health, is one of the major drivers to increase costs and reduce quality of care and increasing health inequalities. So it's very important that you coordinate services for our mental health needs and our physical health needs, and that's what we have in Lewisham Hospital at the moment, a site where you have physical illnesses dealt with in a good quality district general hospital, and the Ladywell unit, which is a good inpatient mental health facility. And that's going to be disaggregated under the new plans. The Trust report shows a typical lack of integration of mental health within physical health planning. And indeed it's ignored in a way that no civilised developed country should ignore it, really.
My name is Dr. Soma Segaram. Yes, I strongly feel that the Lewisham Hospital prospect of being closed is a shocking news for us, because most of our people are on the poor side, they are not wealthy, and they depend on the free health service which the whole country provides, and especially locally provided by the Lewisham Hospital. So I think it is very, very important that vehemently we oppose it, support it, and help in building the hospital even more, rather than closure or making it fully private or something like that.
Jeremy Hunt.
Minister, the changes recommended by Matthew Kershaw must satisfy what are called the 4 tests. Could you explain to us what they are?
The changes must have support from GP commissioners. The public patients and local authorities must have been genuinely engaged in the process. The recommendations must be underpinned by a clear clinical evidence base, and the changes must give patients a choice of good quality providers.
Although the 6 clinical commissioning groups expressed some concerns about aspects of the plans, only one of them, Lewisham, came out in direct opposition. What's your view of that group's standpoint?
Well, of course, I understand its opposition to the proposals put forward by the Trust's Special Administrator, but it supports the principle that complex procedures should be done on fewer sites. That is an important point. Inevitably, when we are reducing the number of sites for complex medical procedures, the people in the areas where those procedures will no longer happen will often be opposed to the changes. Now, that is what has happened here. But the group supports the principles behind what the Trust's Special Administrator has said.
Would you say the vocal opposition from the public, patients, local health providers in Lewisham means that they've genuinely engaged with the plans?
The public campaign surrounding services at Lewisham Hospital has highlighted just how important it is to the local community. I respect and recognise the sense of unfairness that people feel because their hospital has been caught up in the financial problems of its neighbour. However, solving the financial crisis next door is also in the interests of the people of Lewisham, because they too depend upon the services that are currently part of the South London Healthcare Trust.
What about the clinical evidence test?
We have the benefit of senior people such as Sir Bruce Keogh, and many of the Royal Colleges have been involved in the external clinical advisory group, which had significant input on the proposals. Now, one question I asked Sir Bruce was whether there had been sufficient clinical input, and his conclusion was that yes, there had been.
Does the opposition of the Lewisham group affect your conclusions?
I believe the amended proposals meet the 4 tests required for local reconfigurations, and I am therefore content for the process now to proceed to implementation.
Thank you.
We shall now hear from Helen Tattersfield.
Could you give your full name, please?
I'm Dr. Helen Tattersfield.
And Dr. Tattersfield, what is your role?
Well, first and foremost, I'm a GP in Downham, and I have been for about 20 years, I think. But for purposes of today, I chair the Lewisham Clinical Commissioning Group.
Briefly, could you first of all describe who your patients are, the patients that you see day in, day out?
I see genuine residents of Lewisham, as all the GPs do, and I think one of the things I said right at the beginning, I've been a GP for a long time, and that means you build up a really good, close relationship with your patients, and also you know the sort of lives they live and what services that they need. And that's why I stood for this position, because I felt I could speak and stand for the people of Lewisham that I work for.
What has been the effect of the CCG?
The CCG, I mean, we've only really been live since the 1st of April this year, but actually we ran in shadow form last year. And one of the first things we did as GPs when we started was say, what difference can we make quickly? Where is Lewisham not doing as well as some other places? And one of the things Lewisham was not good at was the vaccination of their children. So we looked at this together, we worked with our colleagues in the council and the Hospital Community Trust, and we went from being almost the worst CCG in London to being in the top part of London, and the actual increase was 10%. So we went from something like under 80% of our children being vaccinated to almost 90%, which is in about 6 months, which shows when you work together what you can do.
Now, you've read the decision of the Secretary of State in detail. What do you see as the most serious ramifications of these changes?
One of the reasons that we continually, throughout the whole process, objected to what we saw was going on was that we saw what would happen to Lewisham would be a breakdown in services. One of the things that Lewisham is really, really good at is working together. You've heard lots of speakers today talk about how we work collaboratively. The hospital, right at the centre, has been a part of that. If you take that hospital out, what happens is that we're then having to work with 4 different hospitals. It doesn't really matter how good or bad they are. You can argue about what the process might do to those hospitals, but even if they're the best hospitals in the world, if I as a GP have patients in 4 different hospitals, I have to know 4 different procedures, they have to deal with 4 different sets of social services. It's all incredibly fragmented, and Dr. Sikorsky was talking about fragmentation in mental health services. This process will mean fragmentation in paediatrics, in care of the elderly, in all sorts of things. And it may be that there are a few certain conditions that are looked after better. We've heard about stroke and heart attack. The majority of people don't have those sorts of things. They have simple things that just require a day or 2 in hospital. But if my patients end up in King's, I don't get a discharge summary, I don't know they're even there, and I don't know when they've come home. If they've been at Lewisham Hospital, I know they've been there, I get the discharge from the A&E to say they're in hospital, I get a discharge when they come out, I know that I need to go and see them to make sure they don't go back in again. That sort of thing's really, really important. And I know the doctors at Lewisham Hospital and they know me so that we can work together. There is no way that I can know all those different doctors in all those different hospitals, and so my patients absolutely will not get such a good service.
And what about travel times? How will the change in travel times impact on residents and their carers?
Well, I think we've already heard the impact from different individuals about travel time. One of the things that we said clearly throughout the process, and we argued intensely about travel times, is that whatever it says on paper, it's what people want to do that's really important. When they do maps of the east of Lewisham, say all those patients are going to go to Queen Elizabeth and it will take them that length of time. Well, if they're actually going to go to King's, it's going to take them a whole different length of time. And we know that's what patients will choose to do. So the impact is huge because the travel is costly, it takes time, you don't necessarily visit your relatives as often so they don't get as well so quickly, so there's an emotional impact. But actually we think the argument about travel times in the TSA is completely flawed, and we made that point over and over again. It was what the Picture of Health, which was the previous manifestation of this, fell down on when they actually looked at it and they realised the impact of it would actually be to overburden Kings and Guys and not solve the problem.
Now, I want to ask you about the process, the TSA process itself. Your particular expertise as chair of the clinical commissioning group, how was that considered within the process?
Well, it was considered in that we had to go, we had to be part of many, many meetings. Most of the meetings we were not given advance notice of what was going to be discussed, and we certainly had no papers to look at before we got there. So we were presented with documents and a very quick piece of this is what has to happen without really getting the chance to contest things. If we did contest things, we were just told there's no time to discuss that, this is the only possible solution, there's no time to look at anything else. That was a consistent statement throughout the whole thing. And often we weren't even allowed to take the papers away to look at them afterwards. It was that type of process.
So, in reality, ignored.
In reality?
In reality, ignored. Your expertise was
absolutely,
ignored.
yes.
The Secretary of State claims that the proposals have clinical support. What do you say about that?
Well, I think it's already evident from other people that they certainly don't have Lewisham clinical support. From my colleagues in other CCGs... The other CCGs are obviously in a very different position, and so you shouldn't be too surprised that if their responses were different. But all of those responses clearly stated that they had significant concerns that needed to be answered. And they were also saying that throughout the process. Colleagues in Southwark concerned about the impact on King's College Hospital, colleagues in Bromley on the Prue, and none of those questions have been answered. So again, they've just been brushed over. So no, everyone's happy, this is the best thing since sliced bread.
Now, in your statement, you say that we believe that we could together have produced a solution that is both safe and effective, but the one produced by the TSA is not that. Now, could you elaborate on that? What do you mean by that, the solution that you could have come up with?
Yeah, absolutely. I mean, even before the TSA, we were sitting down seriously with our colleagues at Lewisham Healthcare Trust to say, look, we know that the resources are going to go down, we have to manage within our resources. How can we do this? How can we work better so that we can continue to provide even perhaps better services within the same financial umbrella? We were talking about improving the community services, bringing more things out into the community, helping people actually avoid going into hospital in the first place, something you wouldn't expect a trust to be talking about when you think their income is determined by who goes into hospital. But those are the sort of conversations that we were already having with Lewisham before the TSA came along. We knew there was going to be future problems with finances. We knew there would have to be some rationalisation of services. But we wanted to make sure that rationalisation was done in a way that would improve services for local residents and not make them worse. Our concern with the TSA is that it's been completely financially led. It doesn't take into the risk assessment, needs assessment of our population, and it puts a large number of people at risk that they are not currently at, and we don't think that's a sensible way forward.
And finally, what is your view as to the impact of these proposals on King's and then in turn on GPs?
Yeah, I think it's quite interesting. I mean, we're asked to develop choice and make sure that our patients have choice. One of the things that may well be an outcome of this, if you actually sort of roll it forward a few years, is that the bigger foundation trusts, which are great, I've got no problem with them, will actually have more and more of a share of the market. Because patients will choose to use those. People are not clear about whether the quality of Queen Elizabeth is such that they would feel safe there. They're not sure they can get there. They know where King's is. They know that's a good national place to go. So more and more work will shift, I think, to King's. It is more expensive there. So from a point of view of commissioning for Lewisham, more of our money will be spent increasingly on secondary care services, so there will be less money to be available locally. And what could even happen is that the merger between Lewisham and QE doesn't turn out to be viable if patients don't use it. So you could almost end up with the whole of South East London with one single provider. That's not choice. I don't know that it will happen, but it is potential. Whereas if you allow Lewisham to build itself up, to build on its reputation, be an effective service along with QE, I think patients will have confidence in that, they will use that, it will become a really good, viable alternative to the big foundation trust, and the whole economy of the health service will be better, which is a bit of an ironic outcome. Just one final point I wanted to make, which hasn't really come up today, and that is about the role of the hospital in maintaining the quality of primary care in terms of teaching, and also in training up the next generation of GPs. Almost all Lewisham GPs these days have actually come through Lewisham Hospital, and that's because they learn what a great place Lewisham is to work. If you didn't have the experience of working in Lewisham, you probably wouldn't think about working in Lewisham. You know, nobody knows about Lewisham. We're sort of the underdog, aren't we? But when you've been trained there, you see what a great place it is, you stay. If these changes go through, Lewisham will not be training GPs, so who is going to replace me? Who is going to replace my colleague? Who is there going to be running primary care? We do 90% of the work, and if we're not getting good quality GPs into the situation, what is going to happen to Lewisham?
Thank you very much for being here.
Thank you very much. I want to ask you a question about what the Minister was told by the Medical Director, Sir Bruce Keogh. It may be a letter you haven't seen, so I'll be careful. Tab 2, please, of that bundle. I think it's there in front of you. This was written this year, 30th of January, where the Director was being asked to consider various aspects of the TSA's recommendations and so on. And consensus was a factor that was being emphasised. And I want to ask you about the second page. Is there strong evidence of sufficient clinical input? Do you see that?
Yep.
Right. Now, I want, before, as a precursor to what he wrote to the Minister, I just want to ask you what is in your statement in detail. And it's on page 85 for those who want to follow it. You've said that the Secretary of State claims that the proposals have clinical support. We've shown overwhelmingly in Lewisham that there is no local support. 160 GPs signed the petition against the proposals. A further 140 GPs from other CCGs also put their names to this. The hospital clinicians have produced effective clinical arguments against the changes, and then you mention 25,000 people marched on the streets. Then you say the other 5 CCGs in South East London have each expressed reservations regarding the outworking of the proposals. Now you go into more detail. That's your, as it were, description and narrative. Now can I just turn to what the Minister was told? Under this heading, is there strong evidence of clinical input? And I really want you to just make some observations on this, if you wouldn't mind. I'll just read it so that everyone in the audience knows what the Minister was being told by this review. I can confirm that there is strong evidence of wide clinical input. Operationally, the TSA programme was supported by a clinical advisory group led by a local GP, Dr. Jane Fryer, which built on 2 years... I'd ask for a little restraint. which built on 2 years of preceding clinical engagement. This group included 8 trust medical directors, 6 clinically qualified CCG chairs, the London Ambulance Service medical director, the local director for trauma, and 3 directors of nursing. An additional external clinical panel, chaired by Professor Chris Welsh, medical director for Midlands and East of England, provided additional scrutiny and challenge, including from the Royal College of Midwives and the Royal College of Obstetrics and Gynecology. Now, there is more in this list. I just want to ask whether, in fact, this is a misdescription or whether there's any truth in it whatsoever.
Right. Well, first off, I don't know about the 2 years of preceding clinical engagement. It may have happened, but it didn't involve me, so I don't know anything about that. These people were all at these meetings. I was at those meetings, but the point was that when points were raised which went against the current dialogue, they were ignored. So they were there. The other point I would make about the external clinical panel is that it was made up of specialists who had specialist interests in specialist areas. There wasn't anybody from the Royal College of General Practitioners. There was nobody talking about integration of services rather than fragmentation. So you could argue, yes, you must close the obstetric unit at Lewisham Hospital because you haven't got an ITU and you might get this problem. But what about everybody else who's having normal deliveries who then have to travel, and what's the consequences on them? There was no counter-argument. There was only the one thing always. It was a specialist need and money saving. There was nothing about integration, and there was no input from the Royal College of General Practitioners.
Final question. Is there a record kept of these meetings?
They were all minuted.
Is it available as far as you're aware?
The TSA must have it, and they were all minuted and the minutes were circulated.
Right, thank you.
Brian Fisher.
Could you give your name
and your qualifications for the benefit of the Commission, please.
I'm Brian Fisher. I'm a local GP, and I do some work with the Clinical Commissioning Group and the PCT before that.
Can you tell the Commission a bit about your connection with Lewisham and your length of service in Lewisham?
So I've been working as a GP in Lewisham since 1983. I live and work in Lewisham. My family live in Lewisham, so I have a special interest, as so many other people do here, in the healthcare services in this area.
Now, we've heard the previous witness refer to integrated and collaborative care. Could you please explain to the Commission about care pathways?
Yes. So the way the NHS thinks about people's journey through care is the idea of a clinical pathway. So if you have breathing trouble, if you have COPD, clinical obstructive airways disease, then where are the kinds of places you would go depending on the severity of your illness? What kind of treatments and management would you have throughout your care in the service? And it's a very useful way of thinking about it. What actually should happen is usually determined through clinical evidence. So an organization called NICE, National Institute for Clinical Excellence, looks at all the evidence and sees how these things ought to be done and makes formal recommendations, some of which have to be taken up by the clinical commissioning groups. But how it actually gets implemented on the ground in different places will depend enormously on the relationships and the particular organizations that are involved. So it is a very localized process, but it does depend on a national and evidence-based process.
And have you been involved in developing and formulating those localized processes?
To some extent I have. So, for instance, some years ago, I was involved in trying to think about how we could reorganize some aspects of heart disease services. So at that time, to get some relatively simple tests, the patient had to go to the hospital and see a consultant to have these things authorized and done. And through a process of discussion with the hospital and all various disciplines involved and primary care, we were able to make the process a great deal simpler and have these things done in the community so that the hospital didn't have to be involved at all, and that was a great deal easier for everybody.
And was it cheaper?
I don't know. At that time, the issue of tracking the money was much less of an issue. And I think one of the things that I think national policy is going to impact on this extremely important area of care is because we have, as other people have said, we have turned the NHS into a market. And when you think about the way this trajectory of care going from your own home through to the GP, into the hospital, back into home, and maybe through A&E and so on, through a very complicated set of handoffs and transactions between the different parts of the sectors. If you turn that into a marketized process, you start beginning to fragment care. And the particular way that it happens in this pathway of care process is that through the way the money flows in the National Health Service, if you keep people out of hospital where they want to be in the community, then actually the hospital loses money. It's a completely crazy way of arranging a service. It really makes me angry. So the very sort of sinews of the NHS now are determined by the way this money flows, and the way the money flows actually militates against collaborative cross-sector working.
Over what period of time would successful care pathways that avoid the need for
costly admission to hospital. Over what period of time would those relationships and pathways be developed?
Well, developing these pathways is not straightforward. There are many considerations, convenience, what services are available, what extra demand it has on different bits of the sectors of the service. So they're quite complicated to set up. So those two relatively simple changes that we introduced, which was really about putting tests into access into the community, took, I don't know, 3.5 years to sort out. And it involved a great deal of discussion and thinking, talking to various people in various ways. So these things are really quite delicate and need to be handled really very carefully.
What, in your view, will be the impact of the TSA proposals on these carefully wrought pathways?
It will smash them. So all of these delicate arrangements, all of these careful relationships, because it's really about, it's obviously about clinical care, and it's about organizations working together, but underpinning all of this is a set of relationships between both organizations and people. And what the TSA is doing is basically cutting across all of those. It will destroy the kind of links that have already been established, as other people have said. They will have to be totally rearranged, and that will, set things back, as you can see. If we're taking 3 years to organize very simple things, this will have huge opportunity costs, huge resource costs to make and to re-establish things that work, half as well as they did before.
Just on the issue of cost then, are you saying there would be more emergency admissions, more crises?
I think it's highly likely that that's the case. So overall, as other people have said, I think that this re-disorganisation is dangerous for people in Lewisham. So I'm very sure there will be more emergencies and more, much more emergencies to deal with. Yes.
Are you aware of any proposals in the TSA plan to recover the community-based care pathways?
I think there is a sort of assumption in the TSA that the sort of pathways I've been talking about will get re-established, but the way all of that level of detail is, that certainly hasn't been discussed at all. What I think is really important is for these pathways to work, particularly in this highly constrained financial environment. There has to be a really significant investment in community services. In fact, the TSA report, I think, was very clear about that actually none of this would work if there wasn't very significant investment in community services. So in terms of the care pathways that we've been discussing, that much of it should move, so far as possible, much more should move into the community. And that would facilitate this sort of smash and grab of the rest of the NHS in South London. So yes, I think there has to be very significant discussion about what's happening in changing things in the community.
So far as you're aware, is that a discussion, or is there any evidence of a plan formed in the TSA to deal with, in the short term or in the long term, the impact of the destruction of these pathways?
There's a long list in the TSA report of things that must happen in the community that would provide better care, and I don't disagree with that list. And there is now a process. There are people in post who are beginning to think about what good community care would look like. They've hardly started their work. I am in touch with them, but it does seem a very nebulous kind of process at the moment. And most importantly, in the whole of the TSA report, there was huge capital expenditure to consider all these changes that were going to be necessary. There is no money assigned for the community-based plan on which everything actually is based. It's a travesty.
So what do you consider will be the impact on local people of the destruction of the pathways?
Oh, I think it will be... there's a paper in the BMJ this week which shows that clinicians spend quite a lot of time repairing broken bits of pathways. And I think that is what's going to happen. So the way, the trajectory of care for our patients is going to be really smashed apart, and we're going to have to build them up. And clinicians are going to have to substitute in all sorts of ways, make lots of phone calls to make sure that people go to the right place, double-check tests, do things, you know, duplicate, all sorts of things are going to have to happen to try and keep things safe when the whole structure around these pathways is beginning to fragment.
You've just referred to the need to try and keep things safe. In your view, will the safety of service users in Lewisham be at risk?
Yes.
Thank you very much. The Commission may have some questions for you.
I just wanted to ask you, Sir Bruce Keogh recommending his policies to Jeremy Hunt talks about there being less specialist emergency care at A&E at Lewisham, but it would retain a small but safe A&E department, a small but safe A&E department. And I'm finding it a little difficult to imagine what a small but safe A&E department would be, and I just would be interested in your thoughts on that.
Well, I think Lewisham has a small and safe A&E now. What is being proposed is a smaller and unsafe A&E. And I think that's been clearly expressed by previous speakers. I'm not an expert in A&E, so I wouldn't want to sort of say the detail about it, but I think it is very clear that the proposals are not up to the mark and do not offer as good a service as we currently have.
Thank you.
Yes, yes. Could you say something about the impact that the changes would have on the training of doctors?
Yes. A little bit like Dr. Tattersfield, at the moment, the training of doctors is a little bit like pathways. They are very, you know, there's a whole set of links between different parts of the system, and the doctors more or less smoothly go through those pathways now. And Lewisham is a big and important part of that pathway in southeast London. So what we see is going to happen is that with the changes proposed in Lewisham, there will be serious attrition over time to the kind of services that are available. And so the training will become more and more difficult to keep going, and in fact will almost certainly have to disappear out of Lewisham. Certainly the training for GPs, and I think that also probably applies to the training for specialists as well. So it is going to have a serious impact on the sort of networks of training in our part of London. Thank you.
Thank you.
One thing I just want to make clear before we hear the tweets and before we break for lunch, that Jeremy Hunt is not in the room. It is an actor who is playing his part as best he can. And I think I should say on his behalf, he's an ardent member of the campaign. And so I just want to make that clear. So now over to Jill and Olivia, who will read some of the comments from people around and about.
I hope this works. Yes, it does. Claire Phillips, moving and powerful video testimonies from all communities in Lewisham, which could be repeated across the country.
This is a message from the scroll outside in the foyer. Please add your comments to it as you go for lunch. It reads, a mention for the nurses and layers of other staff at the hospital. They are the fabric of Lewisham Hospital. They are the fabric of Lewisham Hospital, and we thank you for your highly professional, caring and committed actions. We thank you very much. That was one of the comments.
Two comments here. Faux, I think it means false. False Jeremy Hunt just booed off the stage. Hashtag Justice for Lewisham. And then the second one, actor playing Jeremy Hunt being examined by Di Middleton of Tooke's Chambers at the People's Commission.
Okay, another one. This is a love letter to Alison Pollock. Alison Pollock, big red love heart. She tells it like it is. If we follow what she says to the logical conclusion, we have to campaign to cancel all PFI debts in the NHS. Long live Alison Pollock.
And just a final, well, there's lots and lots of comments on Twitter, but Save Our NHS East London, brilliant to be in the audience at Lewisham People's Commission of Inquiry. And it says watch here, because you're probably aware that Obi here is live streaming this onto our website. So if you do have to go home, please don't miss the afternoon, but you can watch us live. Thanks.
Okay. One last comment for this session from the scroll. God, there's so many brilliant ones. Okay, I think we'll be a bit vain. It says, Lewisham takes a lead again. Question, how good is the Save Lewisham Hospital campaign? Answer, stunningly brilliant.
Can I just say, before we go for lunch, a big, big thank you to all the witnesses we've heard this morning. I think we've had a really fabulous morning. See you all at 1:45.